questionnaire that doesn't reflect what you've already done. It has specific questions about drugs. It has specific questions that target Sjogren's possibilities. It has specific questions about age and sex and habits, hobbies and so on. If you've done a proper clinical workup, you don't need a McMullen's dry eye questionnaire. Now, I think for monitoring things, maybe for subjective symptomatology, maybe they're handy. And I think they're very, very good for pre-regs and people maybe coming back, because it prompts you. You can look at it and say, oh gosh, I haven't asked about so-and-so. But if you've done all your stuff and if you've done all your other things, seriously, you don't need them. And I think, again, we've got to stop thinking about ourselves as recipe followers. We've got to think of ourselves as clinicians. Now, so onwards to the workup. Now, you can have technology if you want, but I don't want to mention that particularly. I think you can use everything in a slit lamp, really. And originally, my first look is just under white light. We're looking for blink patterns. We're looking for hyperemia. Look at lids. Now, my patient base is a lot of them quite elderly. So I'm always looking for what I call snapback and distraction tests, and I'll get onto that to explain what that means if you don't already know it. Tylosis, all the things about the lids, conjunctivochalasis, I see a lot of that, tear prism, luster, all these sort of gross things you can just quickly have a look at. Again, my patient before, I didn't put any fluorescein in straight away. I saw it straight away, just under white light. I didn't need any technology to tell me any of that. But one piece of kit I have to say is potentially important now is the tear lab, because it actually tests osmolarity. And if you think back, in the definition, it's the one objective thing mentioned in that definition is osmolarity of the tears. So it's probably potentially the one thing I think that could be a really important thing that can quantify something, whereas all the others, like I sometimes use a topographer just to show the patient how wobbly their tear layer looks, but it doesn't change what I've done. But I think the osmolarity machine, that the tear lab could actually give an objective measure, which would be quite an important thing. Now, I want to mention these things called clinical management guidelines from the College of Optometrists. Now, it's in here. They're not technically a diagnostic aid, but they do give you some information. Now, they're really, really easy to access. They're always compacted down to about 3 pages, so they're really easy to use. They're open to you. You just go into the college, and you can look up. I think they've got about 60 conditions that they talk about. And here's one on ectropion. And when you go through it, there it is in about 3 pages. And then basically what it tells you is it tells you about these tests. Now, I didn't know about these tests until I looked at these particular things. They talk about a distraction test. So if a lower lid can be pulled more than 6 millimeters from the globe, it's lax. Then there's a snapback test. You pull it down, how well does the lid bounce back towards the orbit? And they're a really, really good diagnostic test that helps you decide what you want to do. So and it also then makes the diagnosis and then the referral stronger. So if you're referring someone because they've got particularly poor lid tone, you're actually saying, yes, we did the distraction test, we did the snapback, these are showing that the lid is lax and maybe needs some surgical intervention. So again, you're making a diagnosis, you're putting a very strong referral together for the GP, and this makes us look good. Now, the other thing, of course, is the general staining. So after you've done your white light stuff and your less invasive things, you then just maybe start to decide to put staining in. That's when I tend to put it in. And I'm looking for positive staining with fluorescein. And you look for tear breakup time, of course, you know all this stuff, and the tear meniscus, but also negative staining. And I look for that a lot. And negative staining results because of irregularities in the corneal epithelium, with dark patches where the tears separate quickly. And I think, I'm not sure people always do this, but it's a very telling thing, particularly for dystrophies and so on. So if you see a little bit of negative staining, I think that's an important aspect. And of course, it's the positioning of the positive staining as well. My patient before, again, the entire cornea was stained. Whereas if it's lagophthalmos perhaps, or poor lid blinking mechanisms, you're more likely to have inferior and so on. And I think the positioning of the staining is very, very important. We all know this. This is obvious. Then there's lissamine green. Now, this is a really, really important dye. If you're not already using it, I think most people are these days now, but if you haven't already started, please use it. My only warning is that it doesn't give you the wow factor that fluorescein does. If you put it in a bunch of normal eyes, you see almost nothing, then you might think, oh gosh, what a waste of time, I'll forget this one. But when you actually put it in someone who's truly got a dry eye, and you see the conjunctiva stain the way this eye is here, it really tells you a lot. You know, I think historically we've been fixated with the cornea because we're primarily contact lens practitioners. But now we're starting to look more at the conjunctiva and how these diseases affect that as well. And it links in very much with this guy here called Van B. I always call him Van B because I can't pronounce his name. And we look for lid wiper epitheliopathy as well, which is where you pull the lower upper lid up, down or up, and have a look at the staining along there. And it also stains up mucus as well. So it's a very, very powerful dye. I would suggest you start using it and just see what it looks like, and start using it on a lot of people first to get an idea of what looks normal. And then when you see something abnormal, it'll be pretty obvious. And the other thing I use a lot of is phenol red thread. I never use Sherma, who does? And this only takes 15 seconds. It's very, very comfortable for the patient. It's a tiny little thread, and it helps a lot if you're really assessing tear volume as opposed to other things. I mean, I don't use it very often, but if I truly think there's a sicker type set of symptoms, there's someone who possibly has Sjogren's, then I'm certainly looking for my phenol red strips. Now, this links on then to the, I know there's a lot of words on this slide, okay? This is the revised international classification for Sjogren's syndrome. Now, this is a 6-set criterion, but the first 3 we can do as optometrists, and this is really, really powerful. Simple stuff. Honestly, it's so simple, it beggars belief. You know, they have 3 ocular questions, and then 3 oral questions, and then 2 ocular signs. Now, this has been developed by a different group of people in optometrists, so they have the Sherma test, and they have rose Bengal. But if you have a positive to them now, obviously in our case we replace the Sherma test with phenol red thread, and we replace rose Bengal with lissamine green. And if you have a positive outcome on those 3 sections, you really have a strong referral for Sjogren's. Now, how does the staining test go? The rose Bengal staining test. This is the Van B scoring system, right? All you do is you take your cornea or your eye and you divide up into 3 zones: temporal conjunctiva, nasal conjunctiva, and cornea. And you put your lissamine green in and you have a look at it. No staining at all is scored 0. Confluence staining scored 3, and in between you've got 1 and 2. And you divide it up into the 3 sections and you get a score out of 9. Now, I have to say straight away this, I know this is not a CCLAU scaling system or anything like that, and I know Nathan Ephron would have a field day with this and all the rest of it, but this is not meant to be any sort of grading thing. This is a diagnostic tool, and obviously, like all screening tests or any test, as a standalone test, it's of very little value. But the way it links in with the other stuff, if you've got this sort of test done, coupled with the poor phenol red thread, coupled with an oral questions positive and ocular questions positive, you have a strong referral, right? We're not trying to quantify how much staining is, we're trying to make a diagnosis. Now, the only thing that would better that, again, is back to this tear lab, would be if you could actually do an objective test as well. That would be quite handy as well. But this is a very, very quick and easy way of trying to make a diagnosis. As I say, we're not bringing it down to 0.1 units and all the rest of it like a CCLAU scale. All we're trying to do is make a diagnosis. Now, the other thing about this thing is it has 3 more sections. It has histopathology, it has a salivary gland biopsy, and it has autoantibodies. Obviously, we can't do them. But if you've done the first 3 and you're referring on to your GP, you're saying, we've done this criterion. I even staple a copy of the outcome to it. So I print it off the computer and put it in. You were looking good. And of the people I've referred like this, I can't think of one that hasn't come back positive for Sjogren's in the end. So these are really, really handy. They're so quick, so simple, so impressive to the patient, so impressive to GPs that you know what you're doing. And you're suggesting, I think we should have autoantibodies or whatever. And it looks good, and it's easy. So once we've done all the diagnostic tricks, we've got to then start treating it. But the point is, we don't treat the symptom anymore. We've got to start treating the condition. Now, again, we have levels, don't we? We love quantifying things. Now, I'm going to suggest to you, throw that in the bin, right? You know, say level 1, education, all the rest of it, goes through level 4, lid surgery and so on. If you've made a diagnosis, you go straight to the treatment for that diagnosis. Right? That's it. So, I want to go through some things that masquerade as dry. One of the big ones is conjunctivochalasis, lid parallel conjunctival folds. Now this actually annoys me. Lid parallel conjunctival flows bordering on the posterior lid margin in the primary direction of gaze may be observed in dry eye. Yeah. An accepted Lipkoff grading scale is shown below. So they actually say if you have no folds at all, the increased risk of dry eye is 0. If you've got less than one fold or whatever, grade 1 is a single fold, you've got a 15 times risk of dry eye, and so on, up to grade 3, which is 190 times risk of dry eye. Do you? I'm saying to you that what you've got is conjunctivochalasis, which is actually mucking up the tear layer, mucking up the tear clearance, and is causing an irritable eye. It's not dry eye, and we've got to treat the condition. Now, if you look at a definition of conjunctivochalasis then instead, it's thought to be caused by both the gradual and thinning and stretching of the conjunctiva that accompanies age and loss of adhesion. So basically you've got redundant conjunctiva hanging over the lower lid. That's got to muck up your tear layer, it's got to muck up your tear clearance, it's got to muck up your tear lids and so on, and it's got to give you a wet epiphora and so on. That's what it is. It's conjunctivochalasis, and we need to treat that. Now, you might say to the patient, we're not going to treat it, we can't do much about it. I've referred people for this before. In America, they resect the conjunctiva. They're not as keen to do that here, they don't seem to be. So you might explain to the patient, look, this is the problem, it's mucking things up for you. Perhaps we can talk about lubricants to keep your eye comfortable, but it's not a dry eye. You've got this redundant conjunctiva because you're getting perhaps a little bit old. I do not do that much